Thank you, Sujita. So good evening, doctors. A warm welcome on behalf of Shield Healthcare. I'm Dr. Prachi from Shield Healthcare. And we have an eminent speaker today. And today's webinar topic is Unexplained Infertility. So thank you, Dr. Arockia, Virgin Fernando ma'am. It's a real honor to have you on this platform. Ma'am is fertility specialist, obstetrician and gynecologist at Cloud9 Fertility. Ma'am has more than 15 years of experience in the field of medicine, and Ma'am did her graduation from Stanley Medical College, Chennai, post-graduation from Bangalore Medical College, and a fellowship in reproductive medicine from Spain. Ma'am is a member of various societies, including FOXY and the Indian Society of Assisted Reproduction. So with this, may I invite and request Ma'am to give a talk on the topic of unexplained infertility. So thank you very much, and over to you, Ma'am.
Thank you very much, Dr. Prachi, for your warm welcome and introduction.
Yes, ma'am, we can see your slides.
Okay, I'll share my screen.
Yes, we can see.
Okay. Good evening to all. I'm, as she has introduced, I am a fertility consultant, gynecologist in Cloud9 Fertility, Kamnahalli, and Silverline Diagnostics, Indranagar. I welcome you all to this evening session about unexplained infertility. This is a very common topic, but it is overdiagnosed one. So I felt that this would be appropriate to discuss. Let me go directly to the topic. So the definition of unexplained infertility is, as you all know, it is self-explanatory that we don't know the reason for infertility. So the basic standard infertility evaluation is normal. The assessment of ovulation is normal. There is a normal good ovarian reserve, that is AMH values 2 to 4. The HSG, that is the hysterosalpingogram, shows at least one patent tube. The semen analysis shows adequate motile sperms. All this will explain that it is undiagnosed or unexplained infertility. It can be primary or can be secondary. So it is a subjective diagnosis, and the prevalence is 15 to 30%. So it varies because we don't know how people diagnose that. According to the ASRM, American Society of Reproductive Medicine, 30% of infertile couples are classified as unexplained infertility. So the basic evaluation is normal. There is one patent fallopian tube, documentation of ovulation is there, and adequate motile sperms. All these put together, it gives us these are the criteria for unexplained infertility. Added on to that is 12 months of unprotected intercourse during ovulation, and if it is more than 35 years, even 6 months of trying through various methods and timely intercourse will come under the category of unexplained infertility. So the prevalence depends upon the evaluation protocol. Who has evaluated and how they have evaluated? What are the tests used for evaluation? What is the referral pattern? Who has referred this patient? And interpretation of the diagnostic studies. Another topic is unexplained subfertility. It is under this topic. So there is subtle ovulation defects, there is subtle tubal defects, and subtle changes in the semen or the morphology, the way, the look of the sperms. So age-related infertility also comes under this unexplained subfertility. What is the agenda behind my talk? It is that the diagnosis should be, we have to catch them young. The history taking should give us the clue. We have to optimize the investigation, and we should decide how long we manage them before we go ahead with IVF. What should be the clinician's consideration? The clinician should consider, was the infertility evaluation complete, performed correctly, interpreted properly, when to start the treatment. Duration of more than 2 years is usually recommended. Female, if more than 35 years, definitive treatment is recommended. Cannot just wait for expectant management. What are the potential contributing factors for the unexplained infertility and subfertility? A low ovarian reserve or a borderline ovarian reserve, a seemingly normal AMH, but still the ovarian reserve in the ultrasound, because the antral follicle count is borderline. And low oocyte quality and lifestyle factors add on to this: pollution, tubal function defects, although it is open, fertilization defects, implantation defects. If there are metabolic disorders, genetic factors, immunological factors, and uterine factors like septum, fibroids, and adenomyosis. Role of the fallopian tube is very important for natural conception. So if the function of the fallopian tube is not appropriate, if there is abnormal peristalsis, altered macrophage and immune activity, definitely pregnancy will not happen. So the fallopian tube is very much important for the sperm transport, capacitation, ovum retrieval. The fimbria, the end of the tube, picks up the ovum, transport of the zygote, fertilization, embryo storage, and nourishment. So the tubal factor is very, very important, and that is what we miss a lot of times. The cervical factors, there can be altered cervical mucus because of previous infections. There is increased cell-mediated immunity, and it prevents the sperm or damages the sperm, and it prevents the sperm from entering inside the uterine cavity. Endometrial factors can be because of fibroids or adenomyosis. The receptivity of the endometrium can be altered. That is, the receptive time to receive the embryo can be altered, and if the natural killer cells activity is more, the implantation may be effective. Peritoneal factors, what can be there? There can be mild endometriosis, which can be missed. There can be previous chlamydial infection, which caused antibodies, altered macrophage activities, frozen pelvis, which we don't diagnose by the usual ultrasound. And there can be peritubal adhesions. A small hint can be given in the HSG, which is often missed. And if you see the embryological factors, there can be poor embryo quality, there can be abnormal chromosomes in the particular embryo, so it fails to implant. Immunological factors, there is an immune rejection of the semen. Sometimes the semen is rejected because of that, and if there is autoimmune thyroiditis, endometriosis, which triggers antibodies in the peritoneal fluid, and there is progesterone resistance, increased estrogen. All these may be subtle. There might be mild endometriosis, but because of all this, people will not conceive. And the cervix acts as a reservoir for sperms and prevents it from entering inside. Immunological infertility is also caused by, this autoimmune antibodies, the anti-thyroid, anti-ovarian, anti-nuclear antibodies, MTFHR gene polymorphism. So all this thrombophilic gene polymorphism also causes a lot of problems. And if there is oxidative stress because of your lifestyle issues, it adds on to the immunological infertility. What happens to immunological infertility? There is reduction in fertilization rate, and there is interference in the early implantation rate also. Genetic factors, which is often missed, it can be Mosaic-Turner syndrome. The person might be normal, but still the eggs may not be of good quality, and the fertilization capacity might be affected. If there is balanced translocation, that is, overall the chromosomes are normal, but there might be a breakage, or that it might be translocated to another chromosome. So the person will be normal, but the progeny will be abnormal. It prevents implantation. So abnormal chromosomes in the embryo results in decreased, no implantation, causing infertility. So this and all cannot be found out in general testing. So XX gonadal dysgenesis and premature ovarian failure. All these are caused by the genetic factors. And XY gonadal dysgenesis and Y chromosome microdeletions many times causes low count and motility in men, and those are reported as normal in many centers. And so this balanced and reciprocal translocation FSH LH receptor polymorphism. So they don't ovulate properly, or they don't get their ovulation on time because of this receptor problem, and they don't respond to medicines, also ovulation drugs. Lifestyle factors, of course, smoking. Active and passive smoking reduces the ovarian reserve drastically in women, alters the tubal function, alters the uterine environment. In men, it reduces the mitochondrial activity of the sperms, so increased DNA damage. So it can be, they might claim that we are smoking only 1 or 2 days, but you never know what sort of damage it is causing. And obesity, if the BMI is less than 30, or if it's underweight, all these factors alter the follicular environment, oocyte incompetence. It causes incompetence of the oocyte, so there is no fertilization. So suboptimal embryo quality impairs the implantation, DNA damage, and all these lifestyle factors also reduce to decreased sexual desire and erectile dysfunction. So when a patient comes to me or to any fertility expert, we prognosticate the patient. So if the female is more than 35 years, of course, with unexplained one, then we worry. Then the duration is more than 2 years, of course, it's a concern. Immediate action has to be taken. Primary or secondary infertility. If primary, why? And if it's a secondary infertility and we have a specific reason, act fast. Male factor, referred by a GP or a gynecologist. So that's what I initially told, the referral pattern, who has referred. So that makes a lot of difference. So the unexplained infertility can be overdiagnosed sometimes. So age-related unexplained infertility has poor prognosis. Average, if you don't treat them at all, you just leave them for expectant management without treatment, the chances are just 1.3 to 4% in a cycle, that is chances of conceiving. Incidence increases with age. The chances of infertility increases with age. So in the history, we look at the age, we look as whether they are married for more than 2 years, if they truly had 12 months of unprotected intercourse, did they follow the ovulation period, the fertile period, or do they actually have a knowledge about ovulation? That is very important. Many couples miss that. And early menopause age, why are we considering this? Early menopause is an expression of accelerated ovarian aging. So the chronological age is different from the ovarian aging. And if you see, the time interval between the decline in infertility and menopause is 13 years. So if a woman attains menopause by 45 years, her decline in fertility starts around age 32. So this is the very crucial one. So if one is 32, so and you know the clock is ticking, the AMH levels or the antral follicle count is on the borderline levels, we know the clock is ticking, her ovaries are aging, so we need to act fast. 10% of women in the general population become menopausal by 45 years. So 10% is a good number. So we need to track them and definitely consider them. And we should definitely know that Indian women are 6 years ahead compared to the Caucasian women. So we age faster. That is, aging means, I mean the ovarian aging. Menstrual history. We have to look at whether it's a regular cycle or is it shortening. Shortening is a worry. It shows a decline in the number of follicles and early recruitment of follicles, and the cycles are becoming longer. It doesn't always mean PCOS. Sometimes a failing ovulation, or if it is just before menopause, also there are longer cycles and irregular periods. So we should not miss that premature ovarian failure. So they might have longer cycles before they go into actual failure. Age of menarche, and the age of menarche is of younger age, like 9, 10, 11, we know the reproductive life has been shortened, because if the age of menarche is early, definitely the age of menopause also will be early. So we need to act fast. And the severity of dysmenorrhea, this cannot be ignored, because if they have severe dysmenorrhea, we know that there is a problem. Endometriosis is an underlying problem in that. And if there is amenorrhea, So amenorrhea need not be PCOS always. Always there is a overdiagnosis of PCOS, and they put it as unexplained infertility. It might be an end organ damage. The endometrium can be damaged because of previous TB infection. It might be a premature ovarian failure. It might be other genetic problems which is ignored. Irregular periods. It might be because of PCOS, premature menopause. Please don't ignore this. If there is a damage to the endometrium, if there is thin endometrium, they will not bleed. If there is adhesions, they will not bleed. And if there is a luteinized unruptured follicle because of receptor problems, that is, the follicle doesn't ovulate at all, they need help in that. So if there is a thyroid dysfunction which is ignored or not, it's overlooked, and it's hyperprolactinemia, hypothalamic changes due to the weight loss or gain, all these leads to irregular periods. It needs to be assessed correctly. Obstetric history, if there is history of MTP, of an abortion, voluntary, or it has happened on its own, and we have to look at the year of last pregnancy to ascertain the years of infertility. And if there was a previous dilatation and evacuation, there was live birth or not, if there was a cesarean or full-term normal delivery, post delivery, what were the problems? What were the problems during the delivery? If it was a premature rupture of membranes, is there a chance of infection? That is hemorrhage, postpartum hemorrhage, if it was an emergency cesarean, DNC for retained placenta, all, and contraception, what did they use? If they had a previous history of ectopic, was laparoscopy done? Was it an emergency one? Was there a tubal damage in that? All this, even if the tubes have there been a self-injectomy, it compromises the blood supply to the ovary and causes low ovarian reserve later on. So the previous history of ectopic should give us a red alert signal. Coital history. If there is vaginismus, whether it is real, it is organic, or it's just a psychological one, or if it is erectile or ejaculatory dysfunction, there are multiple partners. Many ignore their adolescent sexual behavior. They don't tell us their previous history. And so that should be kept in mind. History of PIDs, live-in relationship, recurrent urinary and vaginal infection. It's very, very, very important. It shows us that has been PID or repeated infection which affects the tubal function. Treatment history. Duration of treatment. What kind of treatment? Usually ovulation induction and timed intercourse is done. And how long they've taken? Have they taken it properly? Has ovulation been documented in the follicular study? And is HSG done properly? And is the film good? Is laparoscopy, was it done? What are the findings of the laparoscopy? And interpretation of the results. So number of IUI cycles they've undergone, whether definitely it was done after ovulation or egg rupture. Was it a difficult IUI? Was it done after ovulation? Was the semen parameter normal on the day of IUI? All this should be documented, and we should look at the history and see whether all this is there. If something is missing, we cannot take it for granted. We need to assess that again. And surgical history, laparoscopic ovarian drilling, if they might be PCOS, but they'll land up in a low ovarian reserve or AMH later on in life. So that should alert us, laparoscopic ovarian drilling. And endometriotic cyst removal definitely damages the cyst wall. Although the cyst wall is removed, it damages a good portion of the ovary and causes a resistance to treatment in IVF also. So this is a study. Maternal menopause is a predictor of the anti-Müllerian hormone levels and antral follicle count in daughters of reproductive age. So this history is very, very important. Mother's menopausal age. There is a history of diabetes, infertility in the family, anomalous babies, and connective tissue disorders. And there is hypothyroidism for the woman, anti-TPO antibodies, and if they are on antidepressants. All this plays an important role, and if there is antidepressants, definitive corrective action has to be taken. Male factors. Generally, we tell it as male factor, but there are subtle things in that. Previous history of paternity is very, very important. Smoking, how much they smoke, how long they are smoking, obesity, night shifts, sedentary lifestyle, anabolic steroid intake, diabetes is what is, we ignore the male partner usually. Hypertension and diabetes has to be assessed in them. And cryptorchidism, There was a previous surgeries, trauma, scrotal granuloma because of TB, varicocele operation, sexual dysfunction, mum's orchitis. There's long things to go. So scrotal Doppler is very much important. A seemingly normal semen analysis, the motility borderline ones may be due to the varicocele, and that is causing a problem. So we need to assess that. Examination. So whether the BMI is normal, high blood pressure, and secondary sexual characteristics, look for that. If there is hirsutism, if there is hypertrophic cervix and chronic cervicitis. So speculum examination plays a very important role, and we know it is a very big cervix, and there is a chance of infection and ascending infection and tubes being affected, and there is a chance of endometritis, which can cause infertility. So depression causes decreased sexual desire. So the history of their sexual history with their frequency is very, very important, whether they have tried enough, erectile dysfunction because of the medicines. All this has to be assessed. So when the patient comes to us, what we do, we again do a follicular monitoring. We monitor if HSG is done properly or repeated, or do a laparoscopy. If there are some symptomatic women, you feel there is some other factor, there is adherent ovaries, you feel it is endometriosis, and young couple, young age woman, I mean, in her 20s, so it warrants a laparoscopy, hysteroscopy too. Semen analysis again, repeated in a good center, in a fertility center, and because the reporting differs in different labs, a baseline pelvic transvaginal ultrasound, 2D or if necessary, a 3D, AMH, hormonal profile, and please rule out diabetes in males and do all the viral factors. So if you take a semen analysis, definitely 15 million count is what we are looking at, and progressive motility 32% and 4% normal morphology. Every other center outside reports as more than 70% normal sperms, and also the criteria differs, and every other sample which is reported normal outside comes up normal in fertility centers. So that makes a difference. Baseline 2D ultrasound done on day 2 or day 3 is very important to ascertain the ovarian volume. A small size ovary alerts us that definitely AMH count is reduced, or if there is any other genetic factors because of the small streak ovaries. Antral follicle count to assess if there is a adherent ovaries, inaccessible ovaries, to document ovulation, endometriotic cyst, malalignment of the tubes. Of course, tubes cannot be made out, but hydrosalpinx can be made out in the ultrasound. Huge hydrosalpinx, fibroids, polyps, septum, and all this. If you have a doubt about the cavity, if about septum, do an abdominal scan always to see the coronal view. And if there's still doubt, do a 3D pelvic scan to access the cavity, the adequacy of the cavity, if there is a septum or not. Luteinized unruptured follicle. This is a very, it's a challenging thing in routine practice, and if they are stimulated by ovulation induction drugs and there is unruptured follicle, then it is a big problem. So that's why usually in injectables like HMG and HCG can, giving a trigger injection like HCG can solve this problem. But give a trigger injection when less than 22 mm even, otherwise it fails to ovulate, and please document ovulation. So what are the causes of this luteinized unruptured follicle? Endometriosis, pelvic adhesions, NSAID, painkillers use, increased prolactin, and only with oral ovulation sometimes this happens. So next cycle if you replace with HMG, so this problem doesn't repeat. Hysteroscopy. So that is why looking at the follicular studies and checking whether it's really they have ovulated or not is very, very important. If there is a cyst formation, yeah, of course, we should be alerted. Hysteroscopy will rule out all these problems. All adhesions can be removed, and if there is a septum, we can detect it and remove it at the same sitting, and we can check the proximal patency of the tubes, do a flushing of the tubes, and scratching of the endometrium, which increases the implantation chances. So it's both diagnostic and therapeutic also. The role of laparoscopy, there's no evidence of routine laparoscopy, but if there is some other problem, definitely do it along with myomectomy, or if there is a big cyst for some problem or torsion, do a dye test, check whether the tubes are swollen or not. If the tubes are swollen, you can definitely clip the tubes to avoid, because if there is a hydrosalpinx, we can do the clipping of the tubes, and definitely do a AMH level before surgery if there is an ovarian cystectomy, because most of the times AMH levels falls. This AMH level, many come with reports, but a lot of variation. There is a lot of lab to lab variations, and many are interpreted like to be normal. But if you do an ultrasound, check the antral follicle count, it doesn't correlate at all. So AMH is produced by these antral follicles between 2 to 5 mm in diameter. And if you do an AFC also, AFC is the bigger follicles. So the antral follicle count, but both should correlate. If the AMH is low, the AFC also should be mostly low. So if a normal AMH doesn't guarantee that everything is normal, please check it again and where it has to be done. And please recheck with the antral follicle count. So we also do a DNA fragmentation index by halo test, where we detect the DNA damaged sperms. They give that as a percentage. More than 30% is higher damage. So the damage is caused, due to smoking, bad lifestyle, varicocele, previous infection, pollution, advanced age, hot baths, diabetes, cancer treatment, poor diet, and definitely obesity. So this is one study which shows that one abstinence day, just 1 day of abstinence, decreases sperm DNA fragmentation 90% of the selected patients. So we see in our day-to-day practice that for an IUI or IVF, when we do with even no abstinence at all, we find good embryo formation, and chances of the pregnancy increases if there is no abstinence or just 1 day abstinence. So the tubal steno-occlusive disease is very, very, very important cause of infertility. It just may be dilated. The tubes may be just dilated, but not, it still can be open and patent, still cause, it may not function properly. It's because of the pelvic adhesions left due to infection, inflammation, tuberculosis, previous surgeries, abortions. All these together can add on to these problems. So read the X-ray. So this tubal function test, that is assessment of the tubes, is very close to my heart, because many walk into the clinic telling my X-ray report is normal, my HSG is normal, the report is normal. So the radiologist would have reported as normal, but when you look at the X-ray, we can find out a lot of problems like proximal. If there is a block, it's due to tubal spasm. It is overdiagnosed. It is intratubal debris. Because of that also, it can be blocked. In the fimbrial end, if there is agglutination, that is clumping we called. So it causes hydrosalpinx, collection of water, and mid-tubal disease, there is external scarring and fibrosis is there. So let me talk about the category of tubes, how to interpret the HSG, because this is the most misdiagnosed one. So this is category 1 tube. It's a very normal HSG where there is a free spill, both tubes are open, and there's normal preserved distal ends, normal tubal dimensions. And if we do the HSG, there is lack of sharp pain, mild pain only is there. If there is a sharp pain, we know that there is something wrong, or if there is a mild blockage which is opening. So there is no, see, the fimbrial end, the end of the tube is fine. It is not clumped or joint. So this has a good prognosis. So in category 2, we have mild and moderate disease tubes where, yeah, there is spill, there is opening of the tubes are open, but there can be mild peritubal disease, and there can be mild tubal pressures elevated. But in this case, there is high incidence of ectopic. If it's mild one, if the ampullary region is not that much tortuous or dilated, definitely we can proceed with the IUI. But if the ampullary end is very much tortuous, and we know this is that place where ectopic occurs, definitely we need to be cautious about it. Category 3. This is definitely, scarring, dilatation, because it has poor prognosis, but there is no incidence of ectopic. It is bilateral tubal block in this. So there's no need to worry about it. But when we look at it, we know that it's a block. Hydrosalpinx also comes under category 3. We should never proceed with any sort of treatment. If it is a proximal, very near to the uterus, definitely laparoscopic clipping is necessary. And if it is away from the uterus, then we can proceed with our treatment. What is the treatment? What about the same treatment as we give for everybody? So these are the options. This treatment is empirical. We still don't know the reason why they're not conceiving, in spite of all the evaluation, and we rule out. See, when we do a complete evaluation, many who fall under unexplained infertility will be eliminated, and the end of it, not even 5% will be left. That is unexplained infertility. So these are the treatment options. Clomiphene citrate or any oral agent, that is letrozole with IUI, gonadotropins with IUI, laparoscopy, hysteroscopy, IVF, and ICSI. So let's talk about laparoscopy. As already told, it is diagnostic. It is also therapeutic. Mild disease, endometriosis, there definitely we should ablate it, but there's no recommendation for routine one. ASRM guideline 2020 tells 3 to 4 cycles of oral ovulation induction and IUI followed by IVF. This is the protocol we use for every other woman unless they are very young, less than 2 years of marriage and very young girl. So, and if we know a definitive problem, yeah, of course, directly go for IUI or directly go for IVF. If it is male factor or tubal problem or low reserve, we know for sure, we go for it. But if it is unexplained, in spite of doing all the time intercourse and ovulation induction, and the age of the woman and is more than around 30s, and ovulation induction is done, then we go to the next form of treatment, 3 to 4 cycles of oral ovulation induction and IUI, followed by IVF. Even there, if there is no male factor or any other problem in the ovulation, please convince the couple that IUI will help them because it will take care of the subtle defects. Natural cycle IUI is not effective. These are the different treatment modalities. So natural cycle IUI is not effective. Clomiphene citrate and time intercourse in unexplained infertility, it is not effective. Letrose and timed intercourse is not effective. That is what the ASRM tells. So gonadotropins and timed intercourse, of course, it is good pregnancy rate, but the multiple pregnancy risk is more, so they don't recommend that. The next form, letrozole and IUI. There is strong evidence because it is better than expected management. So it helps a lot of couples with unexplained infertility. The next is clomiphene citrate and IUI. Definitely it has a strong evidence that it can help unexplained infertility couples. Clomiphene citrate and gonadotropin combination with IUI, it increases pregnancy rate, but multiple pregnancy rate also increases. But the best would be letrose, low dose gonadotropin and IUI, increased pregnancy rate, less multiple pregnancy. So this letrozole IUI and letrozole added on with the gonadotropin with IUI is definitely a good choice of treatment. That is what we follow routinely. IUI with only injections, gonadotropin injections less than 150 IU, that is low dose. There is no evidence of increased success. The same success rate can be achieved with the gonadotropin and letrozole combination or only with letrozole also. So it only increases the cost. It's not going to increase any success rate, and it gives multiple pregnancy also. So IUI with conventional gonadotropin, that is around 300 international units, is not at all recommended. That is only for IVF. Double IUI is also not better than single IUI unless there is a low motility, or if we feel we have not done a good job and there are 2-3 follicles which is not ruptured, then we can go for a double IUI. Otherwise, a single timed proper IUI after ovulation is enough. And then IVF. So if you take the treatment modality as what all I've explained, this is what in short. Less than 35 years, 3 to 4 cycles of IUI with oral agents, and then go directly for IVF. There's no need for direct IVF. Definitely try with the IUI and then only go for IVF. If more than 38 years, between 35 to 38 is a decision to be taken, but we advise more than 35 even to go, shorten. Don't do 3 to 4 cycles of IUI and then go for IVF. Maybe you shorten that phase, like 1 or 2 cycles of IUI, not conceiving, go for IVF. But more than 38 years, direct IVF, because it gives a shorter time to pregnancy, because we are worried about the ovarian reserve falling. So if we do ICSI in them, that is intracytoplasmic sperm injection, It increases the fertilization rate and prevents fertilization failure. This is a FAST trial done in 2007 for unexplained infertility. It's called Fast Track and Standard Treatment. It is an RCT randomized controlled trial where they randomize these couples into two groups. There is a fast track group and the conventional treatment group. The fast track ones, that is 261 couples. They received 3 cycles of oral ovulation, that is CC, clomiphene citrate, and IUI, followed by IVF. This was the pregnancy rate, 20% in IUI and 68.7% in IVF. Now see the conventional one. What they do in conventional one, 3 cycles of oral agents and IUI, then go for injections and IUI, and then 6 cycles of IVF. And you do so much for this 247 couples, the result is all the same. You see the previous one, 68%, and here also it is 64%. So in IUI with oral agents, 18%, with FSH is 25%. So a fast track one is better. The result is median time to pregnancy is shorter in the fast track group. IVF is the best choice, but for a young couple, less than 2 years of marriage, definitely do an expect and manage lifestyle modification, expect and management, timed intercourse for a couple of cycles, then IUI, then only go for IVF if everything is fine for less than 2 years and young couple, that is less than 30 years. What is the logic behind the choice of treatment? How do I decide the choice of treatment? If it's unexplained infertility, why do I do IUI? Subtle ovulatory defects might be missed. Giving oral agents, I increase the number of follicles to increase number of eggs available for fertilization. So increase density of the motile sperms by doing an IUI. I just concentrate the motile sperms and put it inside. So all these can increase the success rate of pregnancy. In IVF, all the same thing, we stimulate with more than 300 international units of gonadotropins. So there is more follicles, more eggs available for fertilization. The DNA damaged sperms can be eliminated by this sperm slow media, which has hyaluronidase. DNA damaged sperms attached to that, the remaining ones we select for the ICSI, IVF. TISA can be done, that is testicular aspiration of sperms, or if there is high DFI because of previous injuries and varicose heel, the DNA damage is more than in the ejaculate sample. Definite direct extraction from the testis will give less damaged sperms. So that is possible. In this, there is 40 to 50% live birth rate, not the pregnancy. Live birth rate is 40 to 50%, and ICSI can be done. And single embryo transfer is definitely possible, so we can reduce the multiple pregnancy chance. How to optimize treatment? Okay, so we can add on this endometrial receptivity array. There is personalized window of implantation. If there is a failure of one transfer, two transfer, we can add on to the IVF treatment to increase the success rate of pregnancy. It will ascertain which is the time when we have to transfer the embryo inside the uterus in an IVF. Natural killer cells can be increased in the endometrium of certain women. If it is high, we give certain medicines to reduce that. Pre-implantation genetic diagnosis for people who have genetic problems in the family, in themselves, which is diagnosed, and we can eliminate that in the progeny by biopsying the embryos, testing it, and whichever is normal embryo, only transfer that. This can increase the success rate and explain people who have genetic problems or without any genetic problems also. People who conceive or you have not conceived in various cycles, pre-implantation genetic diagnosis can be added on. So we also give immunomodulators, steroids, anticoagulants, immunoglobulins, intralipid therapy for people who have no reason to have for implantation failure. Platelet-rich plasma therapy for if we find borderline endometrium. TISA can be added on, that is testicular aspiration. So all these are done to optimize the IVF treatment. Of course, IVF is the best choice for unexplained infertility, but still we should try the simple IUI method for each and every couple who falls under the criteria. The take-home message is diagnose them early. There should be a definitive treatment. Only expectant management is for up to only 2 years, not more than 2 years of marriage. Referral at the right time is the crux, and lifestyle modification is very, very, very important. Thank you for your.
Thank you, ma'am. It was a detailed presentations, very nice, right from history taking to treatment. You have explained beautifully. Ma'am, one question. Suppose that there is a semen analysis done and there is some abnormality or fragmentation index is a little higher, and no issues with the woman, and probably the patient, male patient, is under antioxidants he is receiving.
Okay.
So in that case, suppose 3 months of antioxidant treatment we have prescribed to the male patient. So in that case, are there any advices to the female as well?
No, there is no advice to the female, but yeah, we give antioxidants if there is borderline increased DFI and we don't find any other reason like varicocele or any other problem which increases DFI. We definitely lifestyle modification antioxidants will help to reduce, and then we can proceed for treatment. For female, there is no when I add in my practice, when I add antioxidants for the husband, I also add antioxidants for the woman to improve the egg quality. Because anyway, we are taking some time to proceed with IUI or any treatment. We're giving that time for the sperms to improve. So during that time, I also add on antioxidants for the women, like this CoQ10, this coenzyme Q, we give for both men and women to improve the mitochondrial activity of both the egg and the sperm. That is one example. And if there is a low reserve for the women or borderline reserve, we advise them to take antioxidants like green tea extracts and wheatgrass juice, and all that will help.
Right. So thank you very much. There was no more question. We don't have any additional questions. So it was a wonderful presentation. Now, thanks for your support, for your time, and thank you again.
Thank you very much for giving me this opportunity and for the support. Thanks to your whole team.
Thank you. Thank you very much from the Shield. Yes.
Have a good day. Nice evening.
Wish you the same.